Welcome to this Satellite Symposium presented by Talaris Therapeutics, harnessing the power of immune tolerance in living donor kidney transplant, FCR-001, an investigational allogenic cell therapy. The speakers for this session are Matthew Cooper from Georgetown University School of Medicine, Suzanne Ildstad from Talaris Therapeutics, Joseph Leventhal from Northwestern University's Feinberg School of Medicine, and Kevin Fowler, patient advocate. Dr. Cooper will also be serving as moderator for this session. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to the session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
I'd like to welcome you all to today's symposium sponsored by Talaris. My name is Dr. Matthew Cooper. I'm the Director of Kidney and Pancreas Transplantation from MedStar Georgetown Transplant Institute. I'm pleased to be joined by a wonderful set of speakers, including a patient whose voice is critically valuable in the discussion when we talk about immune tolerance. In terms of our program objectives, we're going to first sort of set the stage. Anything when we talk about innovation, it's important to make sure that everyone's on the same page. So we're going to make sure that everyone understands the true burden, and that's a purposely chosen word, the burden that's associated with post-transplant immunosuppressive therapy. And importantly, the need for innovation and improvement in long-term outcomes. So when you see some of the data, I'm going to challenge you to think beyond, I've seen that before, and I'm going to come back to that. The next thing we're going to talk about is we're going to introduce the potential of tolerance in the setting of a renal transplant utilizing, importantly, something called durable chimerism with FRC-001, which is an allogeneic cell therapy. We're going to review the long-term follow-up of an important phase 2 clinical trial that was put together to induce tolerance in living donor renal transplant recipients. And importantly, Kevin's going to talk about the importance of the patient as a stakeholder in contributing to innovation in the setting of renal transplants. So again, I have the opportunity to sort of set the stage for our future speakers and for, again, I think getting you excited about the opportunities in this innovative strategy. And so the outcomes and treatment burden associated with standard of care for living donor kidney recipients. Now, again, this is data which I'm going to have you look at with a fresh eye and also with that retrospective scope. This is data which probably many of you know very well, which is, again, the data that demonstrates comparing transplant and dialysis is really like comparing apples and oranges. You can look at the 1 year, 5 year, and 10-year data, living donor, deceased donor, and dialysis. And I think all of us appreciate that transplant is a better option than dialysis, not only for quality of life that we're going to talk about, but also for life years gained. But recognize that this is current data. This is 2019 data, 2021 data, that if you reflect 10 years ago, you might think, those are the same numbers that I saw 10 years ago. And the question that sort of brings to bear is, well, why is that? And why isn't it that we're not getting sort of more interested in how we can improve those numbers? And so, again, we're going to pass by the argument that transplant is better than dialysis. And now we're going to look into the appreciation that, again, living donor and deceased donor transplants is, again, not necessarily a fair comparison as well. The living donor transplant has year over year demonstrated improved graft survival. And if you look at this data, again, 1 year, 5 year, and 10 year, again, this is current data from the USRDS. You think, well, that's about the same data that I remember seeing 10 years ago. And the question still brings to bear, so why is it that we haven't shown significant improvements in those numbers, despite, again, what overall our intent is to increase opportunities for long-term survival with organ transplantation. And if you look at this data, successively cohort over cohort, you can see that really we haven't improved on the half-life in terms of survival for living donor transplants. Sure, the curves are a little bit different, but in terms of life years gained following transplant, we really haven't made significant improvements. And about 1/3 of living donor kidney transplants will require a second one within 10 years. And much of that is due to the effects of immunosuppression, which we're going to talk about. In fact, rejection accounts for 17% of graft losses in the first year and 63% of graft losses even after that first year. And so, again, we're proud of the fact that transplant is a success. But the reality is that as we continue to look data point over data point, year over year, we really haven't made substantive improvements in the long-term outcomes of our transplant patients. And that mostly is due to the fact that we really haven't demonstrated an ability to improve our standard immunosuppression. And how about that immunosuppression? So we all know that the immune system, I describe it as the smartest system in our body. Without it, we'd be sick all the time. But we have to recognize that dealing with the immune system is really kind of the centerpiece of success of transplantation. And chronic immunosuppression is our standard of care. The guidelines recommend maintenance therapy. There, of course, is induction therapies, but maintenance therapies across the board in the United States, the majority of patients are initiated on dual or not triple immunosuppressive agents, including a calcineurin inhibitor and an antiprolific agent. And long term, while we continue to potentially reduce the doses of those maintenance immunosuppressive agents, there still is, in fact, an overall burden. I use that word again, burden of immunosuppressive exposure for many, many years following the success of that transplant. And as the data shows, about 90% of kidney transplant recipients are maintained on a CNI-based immunosuppressive regimen to prevent rejection. And we take the good and the bad with that. The next slide, those pictures, there are some things that when you've been privileged to be in for about 20 years into the transplant space, there are some pictures that you continue to remember and tell that 1,000 words. And acute nephrotoxicity is a real thing. We'll talk about chronic in a second, but when you look at acute nephrotoxicity that are sometimes from supratherapeutic doses, we can't specifically say a specific dose because that's different for every patient based upon their metabolism and particularly with enzymatic degradation. But you can see on the slide the complications associated with acute nephrotoxicity, de novo thrombotic microangiopathy, hemolytic anemia, and thrombocytopenias. And that vasoconstriction can oftentimes lead to a slow recovery, even in the face of a reduction in doses of our CNI maintenance immunosuppressive doses. But again, long-term nephrotoxicity, data that has been recapitulated, this is really pioneering data, hallmark data from Brian Nankivell almost at the turn of the century that showed if you were to biopsy grafts even up to 10 years following transplant, that all of those allografts have some sign of chronic nephrotoxicity secondary to the injury from our CNI agents that we again demonstrate is the need for hallmark for our baseline maintenance immunosuppression. And so the benefits of immunosuppression in preventing rejection certainly do not have a go without having some complications as well. And what are those complications? Well, infections, of course, are the most common. It's the leading cause of complications after transplant. Estimated post-transplant infection rate is 45 per 100 patient years. The common ones that we know of, pneumonias, viral infections, and UTIs. And boy, currently, one of the things that we've appreciated importantly is that the vaccination might not be very successful in patients that are chronically immunosuppressed. And so, again, the complications associated with immunosuppression should not be, again, undervalued or underappreciated. How about then malignancies? We also know that immunosuppression increases the risk of malignancy, which is the third most common cause of death post-transplant. Most common are skin cancers, renal cells cancers, and PTLD, again, not to be taken lightly. And that risk of malignancy is increased, again, at the time with which we measure it. So the longer the burden of immunosuppression, the greater the risk of malignancy, 2.4 times at 10 years post-transplant. And for our younger individuals, again, because of the expected life years gained after transplant, 2.3 times for recipients under 40 years. Again, so infections and malignancies, number 1 and 2 most concerning causes of maintenance immunosuppression. But there's also significant long-term morbidity as well. The metabolic syndrome and the development of potentially post-transplant diabetes or type 2 diabetes as well. We know that immunosuppression increases the risk of hypertension, hypercholesterolemia, hyperlipidemia, and all those not only can cause patient death, but also increase the risk of graft loss secondary to the risk of developing hypertension and diabetes, greater than 3 and 2 times respectively. And then finally, perhaps what is underappreciated is the risk of neurotoxicity. About 1 in every 3 patients experience some form of neurologic complications, particularly tremors that again related to our maintenance immunosuppression. It's one of those things that you, unless asked your patients about, we don't really recognize the significance, I think, in the overall prevalence in our post-transplant community. Let's also not forget that the numbers of pills that we were asking our patients to take, which again, you may not recognize until you have your patients sort of bring their pills into the clinic and you realize, well, it's already complicated enough to be a transplant recipient to worry about those things. And let's not forget, our patients worry. We worry for them, but it doesn't take that away. But it's estimated after transplant that patients take somewhere between 15 and 25 pills a day for life, right? This isn't a temporary thing. This is lifelong maintenance immunosuppression. The complexity can increase, particularly for folks that have the complications, as we talked about the previous slide, with diabetes and hyperlipidemias. At 1 year, 94% of patients have what we would call polypharmacy, and 38% have hyperpolypharmacy, a word I wasn't aware of, but over 10 medications a day, respectively. That's a lot for folks to manage. And you can see with the pie chart on the right, where all those medications are expected to treat. And the most important one is those immunosuppressive medications that are necessary for the success of our transplant. But then we also have to appreciate that there are certain medications then which may be prohibited in our transplant recipients because of their effect on CYP3A or P-glycoprotein, which can change the metabolism of our immunosuppressive drugs and therefore affect the protection with which they are expected to give. And I think we all know that non-adherence certainly increases with that polypharmacy that we talked about, which is, again, I think, an unrecognized complication long-term transplant that we are looking to try and avoid as well. Finally, what I think is, again, a very important piece is that we overlook the overall improvement in quality of life for our patients. This is a small study, but I think it sets up the conversation very well. Looking at folks that have undergone and successfully achieved immune tolerance versus those that remain chronically immunosuppressed, the numbers you can see on this chart. But when you're looking at patient-reported outcomes, which again are becoming, I think, more and more important in the end results of our clinical trials, you can look at patients who were able to be tolerant and therefore no longer needing maintenance immunosuppression, that they reported significantly less problems in terms of physical functioning, an overall improvement in their general health, better socially engaged, increased ability to desire and interest in interacting, improved energy and fatigue. And so overall, the ability to avoid the need for maintenance immunosuppression has been demonstrated as well to improve the overall patient's quality of life. And so again, I think that's a very good setup for kind of where we sit today with this potential opportunity in looking at immune tolerance. And with that introduction, I'm going to hand things over to Dr. Ildstad, who's going to talk about a novel investigational cell therapy for which she has been very much involved with.
As a transplant surgeon, I saw all of the complications that Dr. Cooper summarized that my patients faced after transplantation, and was motivated to find a way to eliminate the need for the immunosuppressive drug. It had been known for over 50 years that bone marrow chimerism, where the stem cell from the donor engrafts induces donor-specific tolerance to transplanted organs, but a safe way to establish chimerism needed to be identified. And in the situation of post-transplant immune tolerance, the recipient sees the donor as part of self, and as a result accepts the donor organs, tissues, and cells, and is still immunocompetent to respond to foreign antigens and pathogens. And essentially, if post-transplant immune tolerance is achieved, then the transplant recipient can discontinue chronic immunosuppression and live a relatively normal drug-free life. The primary challenge to safely establishing chimerism is the requirement for perfect matching historically, and also the toxicity and long-term complications associated with the conditioning failure of engraftment, and a disease called graft versus host disease, where the donor cells attack the recipient. And over time, we essentially looked at ways to prepare a dual immune system where the donor and recipient cells coexist and tolerate each other. And that can be achieved using very reduced intensity conditioning called non-myeloablative conditioning. The other thing that we did was to look at what cells in the bone marrow were required for the bone marrow stem cell to take without causing severe complications of a standard bone marrow transplant. And we used rare event cell sorting to identify a novel cell in the bone marrow that we call the facilitating cell that is CD8 positive and T cell receptor negative. And in an animal model, in a mouse model, we identified the optimal combination of CD34 hematopoietic stem cells plus facilitating cells, plus a very low dose of donor T cells that allow the stem cell to take in very reduced intensity conditioned recipients. And that is the nature of our product, which we call FCR001. It's manufactured from mobilized donor peripheral blood. And essentially giving the bone marrow is very similar to giving a platelet donation. And as a result of that, we were able to cross major HLA mismatches between the donor and recipient and not be limited to having a perfect match for the donor and recipient. We know quite a bit mechanistically about how the facilitating cell exerts its effects on the stem cells and progenitor cells. And we've done a number of studies to show that essentially it's a very tolerogenic cell. It promotes homing and migration of the stem cell to the bone marrow niche and keeps the stem cell happy. Essentially, it prevents apoptosis or death of the stem cells and increases the survival and clonogenicity of the stem cells. And in a recent paper that we've just submitted, we found that facilitating cells significantly prevent the occurrence of graft versus host disease in a mouse model. And so all of these animal models have demonstrated that the FC-based therapies have the potential to induce immune tolerance.
Thank you, Suzanne. I now have the pleasure of discussing with you the FCR001 treatment process for both the donor and the recipient aspects of the trial, and our experience with the phase 2 trial, and then we'll close with a discussion of the phase 3 Freedom 1 trial. So this slide illustrates for you the donor protocol for mobilization and apheresis. Obviously, this is a critical part of the FCR process. Donors undergo at least 3 weeks prior to the intended transplant date in the tolerance induction protocol. This is a mobilized peripheral apheresis and collection with FCR001 processing to create the FCR product. And then, of course, the donor will undergo donor nephrectomy, as you'll see on subsequent slides, as part of a living donor transplant, which takes place the day before the FCR infusion in the context of the non-myeloablative conditioning, which is used in the study. The adverse events in donors undergoing mobilization were quite minimal and very self-limited, as shown on the slide. The recipients also undergo mobilization, apheresis, and cryopreservation of blood stem cells without any sort of manipulation or selection as a standard of care. Rescue autologous infusion if needed following conditioning and transplantation. Following that period of time, the non-myeloablative conditioning has begun day -4. The elements of which include fludarabine as well as cyclophosphamide, with the integration of dialysis to minimize toxicities related to altered renal pharmacokinetics. The transplant takes place following the total body irradiation on day -1. We initiate baseline maintenance immunosuppression with tacrolimus and mycophenolate 2 days prior to the intended day of transplant. The living donor kidney transplant takes place on day 0. with the FCR001 infusion on day 1, and the final elements of the conditioning involving cyclophosphamide and the infusion of Mesna, which is used with cyclophosphamide to minimize toxicities, on day 3. We then, and this is something which we've used routinely and protocolized in the Freedom 1 phase 3, use GCSF to help minimize the so-called nadir period of a low white count in patients until the ANC is greater than 1,000 for 3 consecutive days. Now, immunosuppression and weaning and discontinuation are based upon the establishment of chimerism. High-level donor chimerism, specifically T-cell chimerism greater than 50%, stable kidney function, without evidence of biopsy-proven acute rejection or graft versus host disease, are the triggers and milestones for the minimization and ultimate withdrawal of immunosuppression. There's frequent routine monitoring with a protocol biopsy at 6 months for the first elimination of mycophenolate, following which time another protocol biopsy at month 12, at which point in time the patient may be completely off of immunosuppression, assuming that the other milestones have been met, with a final protocol biopsy in the phase 2 at 24 months post-transplant. And so now I'd like to take you through the exciting data from the phase 2 clinical trial, and then end with an overview of where we stand with the phase 3 Freedom study. The design of the phase 2 trial, there were 37 donor recipient pairs enrolled, 36 at Northwestern and 1 pair at Duke. You can see that both the donor and recipient, as I've mentioned, undergo mobilization and apheresis, with the donor apheresis product being used to manufacture the FCR product. The elements of the conditioning starting pre-kidney transplant and post-kidney transplant, as previously discussed, with the FCR infusion on day +1 following the transplant day 0. And you can see the primary endpoint for the study was durable tolerance with significant reduction or discontinuation of immunosuppression. Donor and recipient pairs were adults between the ages of 18 and 65 who met the eligibility criteria established for the study, and all levels of HLA mismatching between donor and recipient were allowed. There were no limits on the degree of HLA mismatch between the donor and recipient, which stands as a distinction from other tolerance induction protocols that have been attempted clinically. As of the end of 2021, we had 33 recipients with more than 3 years of follow-up, with 21 having more than 5 years of follow-up, with the exposure to the FCR001 being approximately a total of 235 patient years. So the majority of patients in the phase 2 trial achieved this milestone of discontinued immunosuppression. 37 patients who received the FCR and the kidney transplants, 27 of whom in which we established durable chimerism. Now was included 26 of patients where durable chimerism with where we were able to achieve tolerance without a significant issue. It did include 1 individual with durable chimerism who developed graft versus host disease that was problematic in its diagnosis and severe in its intensity, that ultimately contributed to subject death within a year post-transplant. But 26 of those 27 patients with chimerism came off of immunosuppression. 70% of patients had stable chimerism and were off of immunosuppression with no biopsy-proven acute rejection, normal renal histology, and normal kidney function as of the end of 2021. There were 8 patients with transient chimerism and 2 subjects where no engraftment was achieved. Of those 8 subjects with transient chimerism on immunosuppression, we saw 5 episodes of acute cellular rejection, 3 graft losses, and 1 subject death. Most of the transiently chimeric patients lost donor chimerism within 2 to 5 months after transplant. And there appeared to be contributing factors to the transient chimerism, ranging from low cell number in the early phases of the phase 2 trial to patients being sensitized to certain co-infections that may have contributed to graft loss. And there were 2 subjects where no engraftment was observed at the initial assessment post kidney FCR transplant. these two subjects who did not achieve chimerism, one was highly sensitized, and the other had an underlying bone marrow disorder, namely large platelet syndrome. They also were very highly mismatched, unrelated transplants. Now, looking at the follow-up of immunosuppression-free recipients on this slide, you can see that we have greater than 9 years of follow-up for some of our subjects off of immunosuppression, with at least 2 to 3 years worth of immunosuppression freedom on subjects with lesser degrees of follow-up, but quite stable immunosuppression freedom for all subjects who came off of immunosuppression after a year post-transplant. You can also see that there was a great degree of HLA mismatch between donor and recipients in the majority of subjects, including living related as well as living unrelated subjects off of immunosuppression as shown. So no correlation was observed between the degree of HLA mismatch and the ability to successfully achieve durable chimerism or graft versus host disease or other safety outcomes in the trial. We took the opportunity to look at bidirectional HLA mismatch and immunosuppression status using high resolution allele typing for HLA loci. Typing was performed for 12 out of 12 alleles in 29 pairs. 3 pairs had insufficient DNA typing for HLA DPB1 typing. And all the 32 recipients had reached at least 4.5 years of follow-up at this analysis. And you can see the number of individuals in blue or dark orange off of immunosuppression and the degree of match across the spectrum. And so really no correlation between the degree of HLA mismatch and durable chimerism, safety, or graft versus host disease. This slide illustrates chimerism at 3 and 6 months and how it appeared to be predictive of durable immunologic tolerance and immunosuppression freedom. At month 3, 90% or 26 of 29 patients with chimerism discontinued immunosuppression at month 12. If you looked at month 6, that was 96%. And by month 12, 100% of patients with chimerism had discontinued immunosuppression at month 12 and remained off for the full duration of follow-up, with longest follow-up now standing at more than 11 years in some of our subjects. So one of the interesting things about what we hope will be achieved with achieving immune tolerance is that patients will have better long-term allograft survival and improved quality of life. And so the hope is that there'll be 1 kidney transplant per life if we can avoid the downside of immunosuppression and the nephrotoxicities that are associated with it. So this retrospective analysis looked at patients off of immunosuppression and who were tolerant in the orange line, and individuals who would have been, and also an intent to treat analysis in the blue line, and then individuals who received a standard of care kidney transplant at Northwestern who would have been eligible for the kidney transplant trial. And this was an analysis that we conducted of our phase 2 subjects here at Northwestern. There were 26 patients who were durably chimeric, 37 in the intent to treat group, and 132 subjects in the standard of care group. And you can see that renal function was preserved in the chimeric patients with discontinued immunosuppression, superior to those standard of care patients who were on maintenance immunosuppression involving calcineurin inhibitors. So there appears to be a renal functional benefit to being off of immunosuppression with FCR treatment. We also asked whether there were advantages with respect to hypertension and hyperlipidemia in terms of medication use. And you can see here that the FCR subjects off of immunosuppression had much lower need for medications to control blood pressure or lipid abnormalities as compared to the standard of care group. So cardiovascular medication utilization is much lower when you're tolerant and off of immunosuppression. Another concern is post-transplant disease recurrence. A number of trials that have achieved operational tolerance where no durable stem cell engraftment has been achieved has seen disease recurrence be a limiting factor in transplant recipients. Remarkably, in our chimeric patients off of immunosuppression, of 7 subjects who were at risk of disease recurrence, with risk of disease recurrence as high as 55% for some of the diseases we transplanted, no post-transplant recurrence was seen. That's in distinction to the transient chimeric subjects who were at risk of disease recurrence. 2 or 3 had disease recurrence. So none of the 7 patients with underlying kidney-related autoimmune or potentially immune-mediated diseases off of immunosuppression had post-transplant recurrence, suggesting that a tolerance to these autoimmune diseases had been achieved through the donor stem cell engraftment. And this was median follow-up of greater than 6 years. Immunologic reconstitution. This is a very important question. We want to make sure that subjects are ultimately immunologically competent when they engraft with donor stem cells. They may not reject their transplant or need immunosuppression, but we want them to be able to respond to other immunologic challenges. As shown here on the slide, when we're either talking about overall leukocyte diversity in lineages such as T cells, B cells, NK cells, or monocytes, or at T cell subpopulation diversity, looking at the various types of CD4 or CD8 subpopulations, we see excellent recovery out to 12 months in the subjects receiving the FCR treatment. And so immunologic reconstitution does occur within 1 year to 2 years in these subjects, what you'd expect in individuals who successfully engrafted with an allogeneic stem cell transplant. We also looked at the recipient safety profile in the intent to treat population. The 5-year patient survival for patients who received the FCR and achieved durable chimerism was slightly lower than that of living donor kidney transplants patients in the UNOS database. There was graft loss occurring in 3 patients in whom immunosuppression was markedly decreased or temporarily stopped because of severe infections. And these graft losses occurred at different times. There was one at 3 months post-transplant that was associated with a viral septic episode, one at month 9 in a patient who experienced sepsis that was unresponsive to antibiotics, requiring complete interruption of immunosuppression. And then finally at month 47 in a subject who lost donor chimerism at month 4 secondary to CMV reactivation, had to have some of their immunosuppression modified to a more innovative regimen, and then ultimately developed problems with co-infections involving bacteria and CMV, and had developed chronic antibody-mediated rejection, needing dialysis following decline of renal function. There was biopsy-proven acute rejection seen only in the 7 subjects who were transiently chimeric. None of the patients who have durable chimerism who came off of immunosuppression experienced biopsy-proven acute rejection. There was no de novo DSA occurring in patients off of immunosuppression. No infusion-related reactions of the FCR001 was observed. Most adverse events occurred during the first 12 months post-transplant while patients were on conventional immunosuppression. And you can see the sort of AEs and SAEs described in our phase 2 trial and the spectrum of infections that were seen. We saw acute graft versus host disease in 2 subjects. One was grade 2 that was steroid responsive. This patient did develop elements of chronic GVHD with ocular and musculoskeletal symptoms, but he's now off of immunosuppression. And then there was a more severe grade 3 GVHD requiring 3rd-line treatment in a subject who unfortunately had late diagnosis of his graft versus host disease. This contributed to subject death occurring at month 11 post-transplant. Additionally, there were 3 deaths occurring in durably chimeric subjects at various time points. The one I just mentioned in the grade 3 GVHD patient. Then there was a subject who succumbed to pneumococcal sepsis 3.5 years post-transplant off of immunosuppression, who had not been revaccinated per our stem cell protocol against pneumococcus and traveled abroad to a high-risk area. And then there was a subject who was a heavy smoker who 4.5 years post-transplant, again off of immunosuppression, developed lung cancer and did not seek medical treatment for that lung cancer. Finally, there was 1 death occurring in a transiently chimeric subject at 4.5 years post-transplant due to candidiasis and respiratory failure associated with septic shock and aspiration pneumonia. The donor safety profile and the intent to treat population is shown here. Adverse events in donors were mild to moderate with no serious AEs being reported, and were consistent with standard stem cell mobilization type AEs, and occurred around the timing of GCSF administration for stem cell mobilization and apheresis. And so before turning over my time to Kevin Fowler, who's going to be giving his perspective from the patient as relates to the FCR approach, I'd like to close with an overview and discussion of the ongoing phase 3 trial, the so-called FREEDOM-1 study. The FREEDOM-1 trial is designed to further evaluate the safety and efficacy of FCR001. It's a randomized, controlled, multi-center phase 3 study of the safety and efficacy of FCR001 versus standard of care immunosuppression in de novo living donor kidney transplant recipients and safety in FCR001 donors. The primary endpoint is the proportion of subjects who are immunosuppression free and without biopsy-proven acute rejection at 24 months post-transplant. And a key secondary endpoint is change in renal function as measured by estimated GFR from the post-transplant baseline at month 1 to month 24 in the FCR001 recipients. You can see the trial design on this slide. Following informed consent and screening, there's a 2-to-1 randomization scheme to patients being placed into the treatment arm, 80 subjects, or the control arm of 40 donor recipient pairs. At the treatment arm, donors and recipients undergo mobilization and apheresis that we previously discussed under the auspices of the phase 2 trial, and the same type of low intensity conditioning and maintenance immunosuppression. And the choreography for kidney transplant and FCR001 infusion is the same. Following this time, immunosuppression withdrawal will occur if the same milestones of chimerism, absence of biopsy-proven acute rejection or sensitization, and normal renal function and biopsy are achieved with longer-term follow-up. The control arm, patients undergo antibody induction with maintenance immunosuppression in a standard of care fashion. Corticosteroids may be withdrawn, and there's also longer-term follow-up beyond the 24-month dotted line that you see. Inclusion and exclusion criteria are shown here. Recipients are age greater than 18 years, and it's a first kidney transplant from an unrelated or related non-identical twin living donor. Donors between 18 and 60 years would be eligible and willing to undergo mobilization, as we've discussed. And subjects have to have a negative COVID-19 nucleic acid test prior to proceeding. Exclusion criteria include sensitization with a P area greater than 20%, ABO incompatibility, presence of DSA, and the other elements of exclusion is shown on this slide. We also exclude biologically unrelated female donor to male recipients, as this was the category in which both cases of graft versus host disease occurred in the phase 2 trial. And again, issues related to malignancy and bone marrow aplasia is shown. So here's a slide showing an update currently as of this past fall of the 5 subjects that have undergone the FCR001 treatment in the FREEDOM-1 phase 3 trial. You can see that there are 2 subjects who were chimeric at 3, 6, and 12-month time points and have been removed from immunosuppression. An additional subject who was chimeric at 3 and 6 months post-transplant, and then 2 more recently transplanted subjects whose chimerism has not been definitively assessed. These chimeric patients achieved and maintained greater than 50% T cell chimerism at pre-specified study endpoints. So in summary, chronic immunosuppression imposes significant health and quality of life burdens on patients. The FCR001 is a promising investigational cell therapy that may allow establishment of durable chimerism in living donor recipient transplant recipients. It may allow recipients to discontinue immunosuppression while preserving graft function without the development of acute rejection or de novo DSA. And the Freedom-1 trial is designed to evaluate safety and efficacy of FCR001 versus continuing standard of care in recipients and safety in FCR001 donors.
All right, everybody. So now we have some opportunity questions, both to our panelists and hopefully from the audience as well. I'm gonna start by introducing my friend Kevin. Kevin, we've known each other for a long time, which is really good for me, hopefully good for you as well.
Absolutely.
But you've been such a great advocate in ensuring the patient voice is heard in the future, particularly in innovations and opportunities for transplant recipients. So let's start right there. Tell me, what do you think is the greatest need for innovation in kidney transplant?
Yeah, thanks, Cooper, for the opportunity to comment. I would draw your attention to an article that was published in the American Journal of Transplantation back in 2018. And the name of the article was Patient-Reported Outcome Measures for Life Participation in Kidney Transplantation, a systematic review. The author of that was Angela Jew. She's part of the Song Initiative that's based in Australia. And what the study participants, including myself, I was part of the study, is that life participation was reported by the study participants to be critically important to people that have received a kidney transplant. And if you look at the evidence and see how many people are actually participating in that domain in terms of working, the evidence is that the employment is still an area of growth. There's still a large area of unemployment after having a kidney transplant. And one thing I like to point out too, the issue hasn't really been studied that much in the United States. If you would like to learn more about that, I would encourage you to read an article by Dr. Benedetti from the University of Illinois, Chicago.
That's great, Kevin. We may come back to that too, because I have something else I want to ask you. But following up on that first question, so now we're into innovation. So how is specifically the patient voice sort of brought to bear when we're talking about opportunities and innovation for kidney transplant?
Yeah, I would, one thing I would say is that I think that if you step back and think about this for a second is because of the profound gratitude that kidney transplant recipients have for being given a second chance at life. Many people like myself, you become accustomed to not complain about some of the physical and mental challenges. And that situation has only been compounded and made more of a challenge due to the absence of patient-reported outcome measures. And so I think that, if I were to say what's needed right now, if I were to say one concrete action I would ask, and there's a need for an externally patient-focused drug development meeting for kidney transplantation or kidney transplant recipients to comment on the true burden of kidney transplantation, which I don't think is fully understood by the whole community, and why innovation is so important for this community.
Okay, let me then take it a step further. So yep. There's always a roadblock, or it seems as if there's challenges. You mentioned the FDA. Tell me, what are your recommendations? How can we overcome some of those challenges in promoting innovation, utilizing patient voice?
Yeah, and I would just say one thing. I think it just kind of go back to the fundamentals, and I think the FDA has provided good guidance on this. Is that I think through actions, not words, that the patient community must be treated as an equal stakeholder in bringing forth innovation, and that what that entails. And if you look at what the FDA has provided guidance on this, is that the patient voice should be engaged early on in the development process. It should be drawn in through the regulatory process, and even after the product is approved. And I think the key is that the patient voice is engaged in a systematic manner, not in a one-off.
Excellent.
So I guess it's now my turn to ask questions. Is that right?
Well, whoever jumps in first. So I'd be glad to ask some of yours, because otherwise I got bunches of them. So
happy to answer those, but to make this equitable, one question I like to ask for Dr. Ildstad, and this is the one that really is always been very I've been very curious about, is what motivate you to undertake this research over 30 years and to continue this research over that period of time, which I think is quite remarkable and inspiring.
Thank you. Because I believed in it, and it wasn't always an easy road. It took perseverance, and it took our whole team. And it really, as a surgeon, and taking care of transplant patients in my past, I saw what they went through. And until we could find a way to eliminate the need for immunosuppression, it doesn't benefit anybody to go into a huge amount of detail about all the complications the patient is going to encounter, because there's nothing you can do. It's better than dialysis, but the drugs were a necessary evil. And I was fortunate, actually, as a surgery resident at Mass General Hospital, to go to the NIH for 3 years, because my mentor there, Paul Russell, who was the head of transplant, told me I asked too many questions and I needed to think about potentially looking at research rather than just caring for patients. Not that just caring for patients is not important. And it was at that time that it really changed my perspective on things, when we happened to find that if we established chimerism in mice, we could get permanent graft acceptance and didn't need immunosuppressive drugs. And then it took scaling it up and interacting and educating the FDA, because at that time, the FDA wasn't familiar with cell therapies at all. We were the first allogeneic cell therapy that came on board at that point. And now there are hundreds, there are so many cell therapies, and cell therapies is its own field. But just having a great team and really believing that we could achieve it if we maximize patient safety, but still persevered.
But my takeaway from that is that the fundamental belief that there's an unmet need to make lives better for people living with a kidney transplant, right?
Yes.
And that conviction has carried you forward. Dr. Cooper, I'm going to go to you to make this give and take here. What motivated you to be an investigator in the Freedom 1 study?
Well, it's great that I had the opportunity to follow Suzanne in that question and answer, because I'm always amazed at individuals who earlier in their career think well beyond sort of what's right in front of them. Because again, what many of us who've completed some training in transplant, whether medicine, surgery, whatever field that might be, we're bombarded by lots of data and expectations of consistently just trying to meet a standard. And unfortunately, the standard, and I spent a lot of time this with my regulatory hat, is how good are they doing it 1 year? And it's remarkable when you're sort of new to the field, you think, 1 year, like how can 1 year be that big a deal? Like where this is something we should be thinking about long term. And I'll be honest with you, unlike Suzanne, it took me many years finishing my fellowship when I was finally able to sit down and say, what are our 5-year outcomes and what are our 10-year outcomes? And no one knew those answers. It was, well, we know that we're not in a regulatory problem, so no news is good news. But the truth is it doesn't take long for you to recognize that, the complications associated with transplant, namely from the immunosuppression, that again is incredibly important and valuable, and some remarkable discoveries that really led to where we are today. But unless you are recognizing that we've got to do better than what we're doing today, we're just going to continue to find ourselves in the same place, which is an organ shortage, which is similar short and long-term outcomes, quality of life, which is okay, better than dialysis for sure, but really not optimized. And so when folks like Suzanne and Joe and the team at Talaris approached me as this potential clinical trial, I had certainly kept up with the literature and always had known that tolerance is kind of that holy grail that you hear about all the time. The mechanism of action and the thought that had already gone into the phase 2 trials and the development was very intriguing to me. And I had, again, like Suzanne and Joe, seen so many folks that have had suffered complications from immunosuppression. I really wanted to believe that this was the right time for this. And I felt very comfortable and very confident that under this clinical trial and with the support that we would see, that this had tremendous opportunity. And we've been very pleased with the process so far, very pleased with how things are going at our sites. And I think this is really the future. And I think to not gain an interest in this, to do the research and to do the work to try and understand this better, is really being short-sighted and unfair to our patients. So I think now is the right time for anybody who had any curiosity about tolerance, and certainly those that have experience in it. This is something with which you want to be a part of and not on the outside looking in. Your patients demand it, and you will be very satisfied.
I just want to say thank you, speaking broadly upon the patient community, acknowledging that not everything is great and that there is a need for innovation. And I just want to say thank you for that. Dr. Leventhal, what motivated you to participate as an investigator? In fact, you were, I think, the very first investigator in the Freedom 1 study.
Thank you for that question, Kevin. Well, my motivation for participating in the Freedom 1 trial had a lot to do with my involvement with the phase 2 trial and the results that I saw in the phase 2 in the patients we enrolled between 2009 and 2016. It's simply remarkable to be able to get patients off of immunosuppression and see the dramatic impact that that has on patient lives. And it really was very, very gratifying and exciting. And I think seeing this ultimately get taken fully from the bench to the bedside to become an approved therapy that can be available for our patients was really what motivated me to participate in Freedom 1, and excited that we were the first site to actually get up and running and to enroll patients into the treatment arm within Freedom 1. And have been encouraged by those early results of patients engrafting and coming off of immunosuppression.
What do you feel are the largest unmet needs in the transplant community?
Thanks for that question as well, Kevin. There are a number of unmet needs in transplantation and in kidney transplantation specifically. There's the organ shortage. We simply don't have enough organs to transplant individuals who are on the waiting list. We have many people who are dying waiting for a transplant. We have issues of infections that we don't have treatments for, such as polyomavirus, and we have post-transplant malignancies, which we don't have effective therapies for, and that can cause challenges and problems in our patients. But I think what links all of that thematically is the use of immunosuppression. In that immunosuppression, although it's very good at preventing rejection and achieving good short-term results in patients, has a significant downside long-term for our patients. The immunosuppression contributes to opportunistic infections. It contributes to the development of post-transplant malignancies. It contributes to subject death sooner than they should die with a functioning graft due to exacerbated cardiovascular risk. And the immunosuppression, particularly in kidney, the calcineurin inhibitors continue to be the foundation of most immunosuppression protocols that we employ in our patients, negatively influences the allograft to where those allografts can be lost as a consequence of CNI toxicity. And so it comes down to, in my opinion, in very large part, getting away from immunosuppression for our patients as much as we possibly can. And so it's tolerance. And so if we can avoid immunosuppression, if we can achieve tolerance or immunosuppression minimization in the large majority of subjects, Freedom 1 is a start for the living donor population, but there is also ambitiously work to be done to help develop strategies to apply this very exciting therapy to deceased donor transplants. It's a larger percentage of patients we're transplanting. And that, I think, would be just very disruptive and game-changing. If we could change the transplant landscape so that the large majority of subjects getting a transplant don't need long-term immunosuppression, I think that will tremendously benefit patients and really address unmet needs in the transplant space.
My final question for you, Dr. Cooper, is that from your standpoint, from looking at what do you feel are the biggest unmet needs in the kidney transplant community?
Well, that's an hour altogether, Kevin. If you give it,
sure, go for it.
But let me just pick what I think is one of the biggest challenges is let's focus on this particular trial. It is it's certainly requires a village, because we're not talking only about the transplant team, but we're talking about your bone marrow transplant team. We're talking about working with your radiation oncologist. You're talking about longer hospital stays. You're talking about potentially increased expenses on the part of the transplant program. You know, not all transplant programs have the ability to do that, which means, unfortunately, sometimes based upon where a patient sort of calls home, they may have more difficult access trying to get these opportunities afforded to them, which is not right, right? Every patient, number one, should have the opportunity to be listed for a transplant. Everybody should have the opportunity to then receive an organ for transplant. And now I believe everybody should have the opportunity free of immunosuppression after their transplant. Now, that's a pipe dream, and it's going to take many years to get there, but we're going to have to find some ways, to be able to afford all those things for patients. And I think if you look at the data from even a financial standpoint, you'll recognize that going from dialysis to transplant, maintenance immunosuppression to without is still long-term a financial savings, on our healthcare system. Absolutely. But we've got to get everybody at the table to kind of sit down and say, we're going to do this. Right? We've got to get HRSA and CMS and the SRTR and insurance companies, and everybody's got to finally come together and say, we all want the same thing. We all want the best outcomes for our patients. Let's figure out a way to make this happen. So I think the biggest unmet need, quite frankly, Kevin, is getting everybody to the table to agree that, again, transplant is a better option than dialysis, and tolerance is a better option than maintenance immunosuppression.
Yeah, I think that's well said. If you're going to find a solution that's going to be sustainable and permanent, you've got to have everyone there at the table from the beginning. And I'll just say it again: the patient community has to be there too, to be an advocate for this innovation. I'll just say this: just my thoughts in response to that. Loved everything I've heard from both of you, and I thank you, Dr. Ildstad, what you've done to make your career to do this. But there is a need for innovation in kidney transplantation, and the community can do better. We're grateful for what you've done, but there is certainly a unmet need to improve the lives of people so they can live better lives. So thank you both for what you have to offer today.
Well, thank you.
Thank you.
Thank you.
All right, everyone. So hopefully folks can hear us. This is the opportunity for our live Q&A. Again, I think I want to thank the organizers. I want to thank Talaris for really giving an outstanding introduction to the beginning of this year's CEoT. Another great reason for us being together, I was appreciating this morning, if you're on the West Coast, it's really early. So we really appreciate folks who have gotten up to participate in this webinar this morning. I believe some outstanding talks and very important, and thanks to Kevin for providing the patient perspective. We have a couple questions. I'm going to encourage people to enter your questions into the Q&A, and I'm going to get to those. But there's one as I was going through there I think is really important to ask. And Kevin, this isn't picking on you, this is the opportunity. You have been, I think we all know, a very strong advocate for that patient voice. Let me ask you though, is your voice different than the majority of other patients out there? In other words, is your opinion one which is shared by the majority, do you believe, or is your opinion kind of isolated and most folks are, kind of okay? And there's not a right or wrong answer to that. I think it's important to bring forward again what the overall should push those of us in the transplant community to continue to try and achieve.
Man, I think it's a great question. What I would say is that, I would say I'm one voice, but I think it's important to hear from all voices. And I think that there are people sometimes that don't feel empowered to speak up. And I would just encourage the community to maybe hear from people who are silent. And I think that there's just a lot of voices out there that we need to hear from. And how do we create an environment so we hear from all those different voices? I think, as I said earlier in the webinar or in the discussion earlier, I think many people are just so grateful for what they've been given. They just learn to soldier on with some of the difficulties. And if you do complain, sometimes you feel like you're being labeled as someone who's a problem maker, versus saying that these are issues that are interfering with the quality of life. So, but it's a wonderful question, though. Thank you.
Joe, a question for you. From, again, way out west was the comment about, as you pointed out from the phase 2 data, the death rate in that trial, and looking for a little bit more information on it, or your thoughts and or lessons learned that certainly have informed the inclusion-exclusion for this, the current phase 3 trial.
Thanks, Matt. Yeah, it's a great question. I think that we learned a lot during the phase 2. I think a lot of what we learned was that we really need to be viewing these. When you're using stem cells in the context of this approach, you need to be viewing the patient and the patient management really as stem cell transplantation first, and I think adopting many of those strategies that were align more with how things are managed through stem cell transplantation in terms of antiviral prophylaxis, strict adherence to the conditioning which was used, the management of the nadir period, the sort of follow-up that we provided, all contributed, were lessons that we learned that I think contributed to some of the adverse events that we saw and negative outcomes that we saw, that we incorporated, proactively in modifications to the later phases of the phase 2 that had a positive impact, and also have been incorporated into the phase 3. And we learned about certain matching between the donor and the recipient that was associated with the occurrence of graft versus host disease, those 2 cases we saw in the phase 2, which is now an exclusion in the phase 3. So lessons learned that we hope will optimize outcomes for all concerned in the phase 3 trial.
Joe, thanks. And again, one of the questions that Kevin asked me, and important to also highlight the importance and the success of the Freedom 1 trial, is having that relationship with your bone marrow team and with your radiation oncologist. Question by Dr. Kumar was, and it's not specifically in the protocol, but a good question to ask is the vaccination protocol after stem cell transplant, and is that similar to standard stem cell transplant, and are we checking the response to vaccinations after folks have received their cell therapy?
And the answer is yes. These sort of standardized guidelines from the American Society of Bone Marrow Transplantation are the ones that we use and use in the phase 2 and are recommended and incorporated into the follow-up of the patients in the phase 3. I think vaccinations is very top of mind for all of us these days. And the other thing that, of course, that we've incorporated into the trial has been the patients have to be vaccinated against COVID-19, SARS-CoV-2, for them to be eligible, both donors and recipients, in the trial. And we have data, actually, which is quite exciting, about the ability of patients off of immunosuppression to respond. Actually, a poster that one of our clinical research associates, Meg Gibson, is presenting at the CEoT meeting, looking at vaccine responses in our tolerant patients off of immunosuppression. They've all responded appropriately to a variety of the different vaccines being used against SARS-CoV-2, with good antibody responses and no effect on their chimerism and state of tolerance. And so, which is important. You want patients to be immune competent and be able to be protected with the vaccines for the pathogens we know about and the ones we're going to see in the future.
Joe, thanks. Suzanne, a question for you, and again, my thanks for your passion and for your energy and for your devotion to the tolerance and where we sit today. And Joe, we talked a little bit about inclusion-exclusion criteria. I'm going to sort of give you your crystal ball and ask it, how far do you think this could go? Because the question earlier was, how do we ensure that we provide access to all patients? Is there a potential that we could eventually see this as available to all patients?
I think there is. We're doing research right now on expanding it to the deceased donor pool, which would open up the door for liver transplant and heart transplant and kidney. And also with respect to sensitized patients, we have a mouse model of sensitization, and it does take more conditioning, so it may take further research to be able to apply it to patients who are sensitized, who right now aren't eligible for our protocol, but I think it could potentially be expanded, again, through research.
Perfect.
And thank you for your comments.
Again, I encourage folks to take a look at the current trial as written, the inclusion-exclusion criteria. And again, if you have an interest in participating, certainly the team with Talaris would like to connect with you. If you have patients, and Joe, maybe you could comment on this as well. It's interesting to me that the patients that we've enrolled have actually contacted us And I hope everyone takes a chance to look at the CEoT. There's a sponsor lounge where you can look at the Talaris video, which is outstanding. And it actually, the patient that's highlighted there was similar to ours, folks that have a history of polycystic kidney disease. So they have an experience of what immunosuppression is like and the effect it has on their family member. So, I'm curious, what your experience has been with, have patients contacted you, or how has, the connection occurred that you were able to bring so many patients, into this therapy?
Nearly everyone was self-referred in the phase 2 trial. People had been doing research. Many of them knew people who had had a transplant and knew that it did not want to be on immunosuppression, or had loved ones who had had a transplant and had problems with immunosuppression, and specifically sought us out. And we continue to see that in the phase 3, where we continue to have inquiries from people who have learned about the Freedom 1 trial and are looking to enroll in sites. Fortunately, now we have a number of different sites around the country, geographically, including your own on the East Coast, others on the West Coast, throughout the continental United States, which makes it easier for patients logistically to get to a site that has the ability to offer them this therapy in the phase 3.
A question from Dr. Nickerson. Do we know, has the FDA developed a patient-reported outcome measure that's currently being accepted in clinical trials as an endpoint? I don't personally know that answer. I know there were some that were utilized when mycophenolic acid was being developed, but I'm not sure whether the FDA has officially accepted a PRO as an endpoint or as a measure.
I don't think so. I'm pretty confident there is not one.
Okay, but let me ask you a question associated with that, though, because you brought up not only a good point, but something that I'm learning is important in our practice. When you, following your transplant, were your providers asking you not only about were you taking your meds, but do you feel like we asked you enough about complications of those meds? So if you didn't share the information, were you being asked the question?
Yeah, I'll tell you, I actually was very forthright with my transplant team, telling them I didn't feel that something was not right. And I shared that with them, and this is not disrespect to them. They provided great care, but I was really kind of ignored. And I really struggled for about a year and a half due to a number of different factors. And I initiated, and it was just that first year and a half was not a pleasant experience. Let's just put it that way. And I just think that it was a combination of factors. I just got the job promotion, young kids, taking all those medications. It's a pretty big event in your life. And unfortunately is that, the system is rewarded 1-year outcomes, and everyone focuses upon that, and the system rewards that. But I would say I was very outspoken about something was not right, and it just wasn't acted upon. I had to figure it out on my own, quite frankly.
We're also fortunate to have Nancy Krieger from Talaris here, the Chief Medical Officer. Nancy, can you tell me what inspired Talaris to invest in this protocol, invest in this project, and where would you like to see this work go?
So it's the basis of the phase 2. I was at Novartis and was involved with the phase 2 trial, and just saw the wonderful results. Again, I'm like Suzanne, I'm a transplant surgeon, and I used to take care of these patients. And I was trained at University of Wisconsin, so we actually took care of the medical aspects of the patients, and I'd follow them in chronic kidney clinic. And I was just said to myself, my goodness, these guys are all having problems, long term, and what can we do? And I've done some research, scientific research, and I've followed Suzanne's work. So was really excited when Talaris embarked on the Freedom 1 trial so we could pursue it. And like Suzanne said, I think this could be applicable to go beyond just living donor kidney transplants, cadaveric and other types of organs as well. And that's what we're starting to look into.
Great, Kevin. And more questions about ensuring that we work to hear all of the patient voices. You had mentioned about it's an FDA effort to try and ensure that patients' voices are considered. Do you have any further suggestions about how we can to use the word of our questionnaire, galvanize the transplant recipient voice moving forward, and or how do we ensure that the value of a sort of a hard outcome like EGFR at 1 year and a patient-reported outcome, how are they to be held equally?
Yeah, it's a great question. What I would just suggest is that I think what there's really a need is to bring the patient community together with the FDA and just have some discussions to hear from patients and say, this is what it's really like, right? This is a risk that we're willing to accept to find innovation. But I think if you survey the patient community, there universally is a desire for innovation, and there's a universal desire to be part of this to help bring the innovation. But we need to be heard as one, and we need to be included in what are going to be endpoints. The patient report outcome measure is an important one, but I think we just need to be a stakeholder. And I think that there is a mistaken belief sometimes that everything is great in transplant. And granted, a lot of progress has been made, which we're grateful for. But I have the belief, as Dr. Ildstad does, that we can do a better job. And my message is leverage the patient community and the patient voice.
Kevin, thank you. Joe, let me ask you this. So we have, and thank you again, we have a large number of people online here who have gotten up to participate in this morning symposium. What do you say to a provider, a coordinator, a pharmacist that is looking at all this and saying, boy, I don't know, that seems like a lot of work. What's the message that you want to ensure people walk away with, when they are sort of considering beginning this journey of tolerance at their institution?
Well, I think it's a lot of work, but it's what we do is a lot of work. I think something which is what's different is we're sort of merging stem cell practice with solid organ practice. And in fact, the work's already being done. I mean, essentially what we're doing is in integrating the journey that a stem cell transplant patient takes with what we're doing with solid organ. And I think something which is new and different if you're in the solid organ transplant world, once you see that there are well-established practices and protocols for doing this in your stem cell transplant program, I think it's really just a matter of getting people together and sort of getting aligned on how the patients are going to be managed. I think the centers that have well-established stem cell transplant programs have an infrastructure that works extremely well for taking patients through this combined kidney stem cell transplant protocol. And so one of the things that we have done to try and get people more comfortable with the FCR approach in kidney transplant has been to take the time to meet with them and go through our experience, all of it, not just the great outcomes, but also the lessons that we've learned, and discuss how the patients are managed. And I spend a lot of time giving in services at my institution to people on my transplant floor, the stem cell transplant folks, the people on our clinical research unit, our blood center, all the areas where the patient makes their journey through the process. And it's something we have to continually do with the sort of turnover we see within our institutions and new people coming in. And I can tell you, generally, people are very excited when they hear about what we've done, and they see that we've been a center that's been part of this. We without exception, have gotten people to buy into it as an institution. And so I think taking the time to do that and orient your team members, and like you said, it takes a village, Matt, is a very good way to successfully do that.
Joe, I'll just steal a minute to say, at our center, similar experience. We've had 2 patients that we've enrolled in the protocol, and their results are outstanding, but they have become in some ways the spokesperson for the clinical trial because they are so enthusiastic. They came in looking for it, and now coming out the other end of it, they're so pleased about now what their future looks like compared to what their fears were. I want to be mindful of time. So I want to first thank all of our speakers. A smart man surrounds himself with much smarter people, and that's what I did this morning. But I'm gonna give Kevin the opportunity for the last word again as our patient. Tell me again, Kevin, what, from the patient's perspective, speaking to patients, what would you tell them now, having this experience of hearing about this clinical trial? What's the message that you would like to be certain to share?
Yeah, and I think Dr. Leventhal really said it best, is that I think if you have interest in the trial, I think like Dr. Leventhal said it best, is just, learn about the trial, have someone explain the different aspects, and feel free to ask questions. But I think the way that Dr. Leventhal said it best is it just takes some time for people to understand this process and to learn more, and just feel free to raise your hand if you want to learn about it. That's my advice.
Kevin, thanks very much. So on behalf of Suzanne, Joe, Nancy, Kevin, and myself, I want to thank the AST. I want to thank the organizers for CEoT. I want to thank everybody for participating in this morning's symposium. Please visit the sponsors lounge. Make sure that you get a chance to mingle with each other. I hope everybody enjoys this year's CEoT, and we look forward to seeing you in upcoming sessions. Thank you to everyone.
Thanks, everybody.
Thank you.
Thank you.